Good evening, everyone. A very warm welcome to one and all. We have gathered virtually today to attend one of the elite lectures organized by the Dental Council of India. The Dental Council of India has been actively contributing to the dental society by conducting online webinars. Before the start of the webinar, there are certain instructions for the attendees. At the time of registration, complete and proper details must be furnished. No request for any change or modification in the details shall be considered. An e-certificate of attendance will be conferred to all the undergraduates, the international attendees, and non-dentists on the registered email. The certificate will be sent to the attendees by email within 3 days of conclusion of this webinar, and they should have attended this entire session of webinar uninterrupted. Please do check your junk email folder just in case the certificate email got delivered there instead of your inbox. If anyone has missed any of the DCI's previous webinars, they can go on to the DCI website and they can go on to the webinar archives and have a complete webinar being presented there. A feedback link will also be provided with the certificates, so please spare a few minutes of your time to duly fill it and send it to us. Now, Dental Council of India has conducted various webinars in the past few months, and numerous colleges have participated in these webinars. From the last webinar, statistics showed that these are the 5 dental colleges with the highest participation: St. Joseph Dental College, Elur; Sardar Patel Postgraduate Institute of Dental and Medical Sciences, Lucknow; Guru Nanak Institute of Dental Sciences and Research, Kolkata; Indraprastha Dental College and Hospital, Ghaziabad; Saraswati Dental College, Lucknow. Congratulations to all the colleges. Well, coming ahead with today's webinar, that is the topic of choice is early childhood caries. Now, this topic always has been a dilemma for undergraduate students, and they are still curious to know about what is the difference between early childhood caries, the rampant caries, then the baby bottle decay. There are so many terminologies associated with this condition. So today, to make this entire topic completely interesting, as well as to completely make sure that the undergraduates grasp it at their level, we have with us one of the most elite speakers of the country, Dr. M.S. Muthu. Now, to introduce Dr. M.S. Muthu, he is currently the chair of the Center for Early Childhood Caries Research, Department of Pediatric Dentistry, Ramchandra Institute of Higher Education and Research, Chennai, Tamil Nadu. He has finished his doctorate in the year 2010 and conferred membership of the Royal College of Physicians and Surgeons of Glasgow in the year 2016. He is the Joint Secretary of the Indian Society of Periodontics and Preventive Dentistry and the General Secretary of the Indian Society of Dental Traumatology. He is the Chair of the Global Task Force on Cleft Without Caries. He has 70 publications in peer-reviewed journals with 10 systematic reviews, including 4 Cochrane reviews. He has also authored 2 well-known books for Elsevier publication. He is the first Indian to receive the prestigious American Academy of Pediatric Dentistry's Paul P. Taylor Award for the year 2020. He serves as a member of the membership committee of the International Association of Pediatric Dentistry and is a member of good standing in American Academy of Pediatric Dentistry, International Association of Pediatric Dentistry, International Association of Dental Research, Indian Dental Association, Indian Society of Dental Research, Indian Association of Aesthetic and Cosmetic Dentistry, Foundation for Orofacial Myotherapy, and the Indian Association of Forensic Odontology. So he will be enlightening us on the topic early childhood caries. Question are the answers. We welcome you, Dr. Muthu. Over to you for this wonderful webinar. Thank you so much.
Good evening, everyone. My sincere thanks to Dr. Baliga for such a wonderful and warm introduction. I'm happy and privileged to be here representing Dental Council of India to present the topic on early childhood caries. At the outset, my gratitude to the office bearers of the DCI, the President, the Secretary, the team which is coordinating the webinars, and with the biggest of the audiences any speaker can ever imagine. And I should admit that probably this is the biggest platform I'm speaking in the last 20 years. So I'm grateful for that. The title for the presentation today is Early Childhood Caries, Questions Are the Answers. So this comes to you from the Center for Early Childhood Caries Research, Department of Pediatric Dentistry from Ramchandra University. This is almost 10 years back in November 2010, during our National Indian Society of Pediatric and Preventive Dentistry Conference. The pictures what you see were taken there, and the slide what you see on the left, that's my first slide of the presentation in November 2010. The same title. And I'm going to show you the conclusion slide of that presentation, which I made in November 2010. I just going to read the 3-4 lines, which is highlighted in red. At that point, I decided to work for the next 10 years on early childhood caries, focus on early childhood caries, spend all your time in research on early childhood caries. So what I wrote there is, at this point, I thought I'll make my efforts to do something about this disease in the next 10 years. The journey has started. I suggest you all to look into this issue a little more seriously. I've shown you the paucity of work in this area in our country. After all, many solutions have come with the right questions. At that point of time, as a clinician, as a researcher, as a faculty, there are so many questions we had. But in this 10 years, we have found many answers for the questions. And we are very, very confident about the answers we found. Does that mean the questions are over? No, we have more questions now. Okay, but however, with the 10 years spent in this area, we realized that at SICRI, we believe that it is 100% possible to prevent early childhood caries. It's 100% possible. So 90 to 95% is a simple possibility. So we've tested on few patients, few group of patients, and we're working on protocols. In the next decade, you will see all these things happening from Center for Early Childhood Caries Research. So this is the brief outline of the presentation for today. We look at extremes of early childhood caries to start with. I intentionally put that element there because I know there's a large group of undergrad students are here. A lot of faculties from different dental colleges are there, and various specialty people are here. So it's very important for me to highlight certain aspects of this disease, probably which is not come to the light till today. So we look at definition terminology and youngest age where it can start, and some etiological and risk factors. We look at clinical features. We spend some time on quality of life of children with early childhood caries. We will address management. We also look at the outputs from SICRI, and also a little bit on the startup in alignment with National Innovation and Startup Policy. And we'll conclude. So this is going to be the brief outline for today's presentation. To start with, the extremes of early childhood caries, how bad it can go on. You know, what's the worst you can see? So this is one of the child. This is the second child in the last 20 years. We have extracted all the 20 teeth. And this happened in 2018, okay, in our department. It was done under general anesthesia. Almost 20 root stems, except there were 1 or 2 teeth which had some amount of tooth left, okay, but some history of abscesses, and there was a fractured tooth as well. So technically, we had to pull out all the 20 teeth. And this is the second patient. This is done in my practice. And this guy was 4.5 years old. And his father was working in our canteen in the university. And this guy used to drink only milk even at 4.5 years of age. The only other as a food intake he used to have is something called milk rice. Because he cannot chew anything, he cannot bite anything. And he's just left with 4 second primary molar which were intact, but because of inability to use the front teeth, he's only living on milk and milk rice for 4.5 years of age. You can imagine. So this again, we extracted all the 16 root stems, okay, and these were the root stems which are pulled out, okay, and this is the X-ray which I wanted to show you all. These were the 4 stainless steel crowns which we placed. And this is 15 months after the procedure, okay? And if you closely observe the mandibular right second primary molar stainless steel crown, it has perforated. Okay, the parents were telling, doctor, after the treatment, with these 4 teeth, he tend to eat every possible food substance in the which is available to him. He has eaten all the vegetarian food substances and non-vegetarian, everything possible. He bites with the 4 metal crowns on the mouth. The moment you eliminate all the sources of pain and sensitivity, the life of a child with full-blown early childhood caries dramatically changes. And this is one such example. So I want you to pay a little more attention for the next 45 minutes probably, and we will completely give you a different perspective towards the etiology and risk factors and what can be done as a general dentist when you can intervene early. What are the early intervention protocols? We'll look at it today. So to a large extent, it is neglect both by the profession and the parents, because as a profession, we fail to see this child at the ideal time. The ideal time is as soon as the first primary tooth comes into the mouth. We all know that. Theoretically, we have read that first dental visit should begin as soon as the first primary tooth comes into the mouth or by first birthday. But do we practice that? Do we follow that? Do we instruct that? Do we convey this to the adult patients who visit us? As a dentist, do we do that for our own children? All these are questions which has to be asked, because there is a great possibility if this one change can happen in this country, bringing the child to the first dental visit by 1 year of age or as soon as the first primary tooth comes into the mouth. So that's the primary goal of this presentation, what you can do at that time. I'm going to show some couple of cases as well as some rehabilitation cases as well as we go along. So somewhere we missed this, and the prevalence of the disease is so high and so many thousands and thousands of children are affected with this problem. So the second part of this presentation is, let's look at how do literature defines early childhood caries. What is the terminology? What is the definition? So this is one of the most complex definition probably you could come across in dentistry, because it has a definition for early childhood caries, and then you have 2 supplementary definitions for severe early childhood caries. This was the original definition which came up in 98 onwards, after the first early childhood caries conference. And it looks okay, you can read and you can understand this, but there are many, many platforms, many workshops, many lectures with pediatric dentists, with the general dentist, with students. And after putting this definition, then I give them some scenarios. I ask them whether any of this, what you see in this slide, is early childhood caries. I put this question, I ask the audience, is a 2-year, 10-month-old with only one single first primary molar with occlusal caries, do you call this as early childhood caries? Or a 2-year, 10-month-old with a buccal surface, only damaged, will you call this as early childhood caries? Many times there is a mixed reaction for these questions, because the definition is there, but practically when you apply it in the clinical scenario, the clarity of diagnosing this is not there. Many times I've seen this, so that's why I intentionally kept this, because it's a simple way you can understand this definition. Okay, I'll show you now. If you look at all these 4 scenarios are early childhood caries, but however, the students are in the initial years of pediatric dentistry training, the students tend to think that early childhood caries means you need all the 4 front anterior teeth to be damaged. Whenever you say multiple teeth damaged, they will try to connect to it. But when you say only one tooth is damaged or one surface is damaged, is it early childhood caries? Now let's look at the definition again. See, you look at this scenario. This is a patient, say 3.5, 4-year-old, only one second primary molar, mandibular second primary molar has a deep cavity. Is it early childhood caries? Let's look at another scenario. So this is a 14-month-old child. There is some white spots are there. White lesions or hyperplastic lesions are there. Is it early childhood caries? Now, if you go back with this clinical scenario to the definition again, you'll understand it better, because it says presence of one or more, even one or more. Okay, we have to understand this. Second thing is non-cavitated or cavitated. One non-cavitated or cavitated, or one or more non-cavitated or cavitated, means even a single tooth, even a single surface with only a non-cavitated lesion, if it has happened on a child who's less than 71 months of age, it is early childhood caries. So basically, if the child is in primary dentition, okay, 6-year-old, no permanent teeth have come, any sign of cavitation, whether cavitated or non-cavitated, your diagnosis is early childhood caries. But do we do that in the college? Do we do that as an intern? Do we do that in the department? Do we diagnose these scenarios as early childhood caries, or do we write as dental caries? So now they revised this definition. Let us not go into severe early childhood caries because it's no more there. They've taken it out. So this is the current definition or the terminology, which says that early childhood caries is defined as the presence of one or more decayed, cavitated or non-cavitated lesion, missing or filled surfaces in any primary tooth of a child under age 6. So there is a limitation to this definition, because if a child is 7-year-old, no permanent teeth have come, only primary teeth is there, they will not fit into this category. But that is that's a known limitation of this definition, but that's okay, that's the current definition. If you look at the late definition, it's amazingly written definition of this disease. Tooth decay in preschool children, which is common, mostly untreated. You underline this word, mostly untreated, and can have profound impact on children's life. I'm telling you, spending 10 years in this, we have not understood or researched many of the general health issues associated with this disease, with children have this disease in a severe form, with multiple teeth damage, as I've shown in the extreme scenarios. You know, it's a debilitating condition. So it's very important that we see it that way, okay? So with this terminology and understanding of early childhood caries, the youngest age when the disease can occur, you know, let's look at some images, okay? If you have this question, I'm going to run through some of the pictures, which are from 14 months of age to 3 years of age, okay? Say, look at this. This is probably 18-month-old or 20 months old, okay? The damage, you look at I want you to closely observe the variation, the pattern, the difference in the damage or the extent of damage, okay, in individual teeth surfaces. Actually, it's only a very small percentage. You put up, I have thousands of pictures on this. You put up all these pictures, each picture has certain amount of variation, the way it has happened, okay? But the disease is the same, okay? This is a 3-year-old, okay, full primary dentition, okay, all the teeth have erupted. So this is again probably 14 or 18 months old. You know, I don't think the second primary molars have come there. Okay, look at the damage, including the lower anteriors. Okay, this is a 1-year, 10-month-old child. Look at the amount of dentine exposed. And you can, if you think as a researcher or a scientist, you know, many questions can come in when you look at a scenario like this. The same tooth has come into the mouth. Okay, same oral cavity, same environmental factors, but the damage is different. Okay, you look at the right maxillary central incisor, the incisal half of the tooth is erupted already into the mouth. That came into the mouth first, but that has not got damaged. But the middle and cervical third has got damaged. Why it should happen that way? And there are reasons for it. Okay, so you look at the pattern, the way the damage has happened, the surfaces involved. You can infer so many things from the way the diseases happen. Okay, so look at a couple of more pictures. This is another 3-year-old. Okay, upper anterior incisors are affected, and you look at this. This is again an interesting picture. So you imagine this upper maxillary right and central incisor before cavitation. Do you think there is a possibility there could have been a slight overlap of the mesial surfaces of one tooth over the other? You just imagine, you put an imaginary line on the picture, what you see in the screen, the mesial surface. You basically draw the mesial surface of the incisors of both the incisors. I'm sure that you will understand there will be definitely an overlap. So does contacts, interproximal contacts, play a role in the way the disease manifests? Okay, on the interproximal areas? Yes, it has a profound impact, significant impact. Many of these things are not studied meaningfully yet. Okay, look at this. This is another 3.5-year-old child with pulpal exposure. 3.5-3-year-old child. This is a 14-month. You know, I'll show you the follow pictures of this. This is a very interesting case study. This is one of her very successful early intervention procedures. So if you look at this, this is a child who was part of a cohort. We studied the sustained anticipatory guidance protocol. Look at the 7 months, 12 months, the teeth have come fully, and the cervical part started eroding. 17 months, it's almost more progressed caries. 21 months, only root stems are there. The reason I put it is you have a very, very short window. When the disease sets in, it develops, you intervene at the earliest possible time so that you don't get damage to the posterior teeth. If you miss that, when it goes to the posterior teeth, it goes on. And there are multiple other things that are involved in this. Okay, so we will try to understand this today. So youngest age, this can happen as soon as the tooth comes into the mouth, okay, and as early as 12 to 14 months of age. So the best possible thing what we can do is visit a pediatric dentist as soon as the tooth comes into the mouth, or by first birthday if no teeth has come. That's the best time to visit. Okay, even if you're a general dentist, you are seeing an infant at this point of time, there are multiple infant oral care measures. You can teach them how to clean the baby teeth. We will address a couple of them in this short presentation. So a quick brief recap what we did. We looked at extremes. It can affect all the teeth, in fact almost 20 teeth. And we defined early childhood caries. We understood that caries in primary dentition, okay, caries, any form of caries, even one tooth, one surface is early childhood caries. The youngest age can be as soon as the tooth comes into the mouth. So into the next section of this presentation, if you look at the etiological factors, the role of feeding practices, okay, we'll delve into this a little more, because one of the very, very strongly associated with etiological factors is sleep time feeding practices. I've changed it. It's not nocturnal, it is sleep time, because we have spent reasonable amount of time in studying this. So we call it a sleep time feeding practices because the child doesn't sleep not only in night but also in the daytime. They take a couple of naps, sometimes in the morning, sometimes in the evening. Even at that time, they take milk at the beginning of sleep or in between sleep. So all these things happen. So it's a very, very strong factor which is associated mainly in children of 1, 2 years or 2.5 years of age. After that, the disease process gets a little more complex. The environmental factors, diet factors, multiple other things comes into play. But the main potential etiological factor revolves around sleep time feeding practices. Okay, so let's keep this. Apart from that, dietary practices, yes, very strongly, and improper oral hygiene practices, because most of the parents do not know how to clean baby teeth. What are the oral hygiene aids you have? So it's very, very difficult for them, or they are unaware of it, or nobody have taught that, and everybody thinks that milk teeth will go and you don't have to clean it. And in front of their eyes, this disease develops, and teeth one by one breaks down. And many, many times they visited a dentist. Many of them, almost 8 out of 10 patients who come with a full-blown disease to me or to the department, have visited the child at 1.5, 2 years of age. One of my biggest requests to the biggest audience I'm talking to, please let us not say it's milk teeth, it will fall. Okay, let us forget this sentence. Let us work on how to handle this and how to prevent this disease as a large healthcare community. Okay, so it's an important piece of information. You look at this, there are a couple of scenarios, because there is always a conflict with breastfeeding and bottle feeding, pediatrician, pediatric dentistry society, pediatric society. See, these are two examples, the next picture and this one. A 18-month-old child, never used bottle till now, but on-demand breastfeeding. The child feeds at least 3 or 4 times in the night time. Okay, I want you to closely observe. The incisal edge is not affected, but the middle third is affected. That's an important question. And also, if you look at the affected area, the borders of the affected broken down part, still you see some opaque patchy spots there. So we know it's enamel hyperplasia because it's a weakened enamel. On the weakened enamel, anything accumulates will break down. It doesn't matter. Only thing, the most common substance which accumulates for prolonged duration in childhood at this age is milk. So that's why milk is being blamed. It's not the breast milk, it's the surface on which it accumulates could be the major reason. A weak surface, you replace the milk with anything else, anything which has sugar, anything which has carbohydrates, it's going to break down. But the most common substance being milk, so we tend to blame this. We are not against breastfeeding. We have to work around on children who have this enamel defects, developmental defects or hyperplastic areas. We have to be extremely careful if we feed them in the night time, in between sleep, because it tends to accumulate on this weak surface. Prolonged demineralization happen. There is no chance for remineralization because there is no saliva in the night time, and technically it breaks down. Okay, and the longest accumulation time is associated with milk because they take 3 or 4 times in the night time. So this is another child 14 months. Okay, I'll show you the post-op pictures later on in this presentation of these children. Okay, again, never use bottle. How can this teeth break down? Okay, so this is a very, very important factor. Again, I reiterate, we want the children to breastfeed up to the recommended time frame. But if you see enamel defects on the teeth, be careful about it. You can feed when the child is awake, or at least the child should be awake for 20 minutes after you're feeding, so that such things doesn't happen. And you also should clean with a wet cotton or gauze after every meal and every feed. It's a very, very important advice to be given to the parent if you see a patient at this point of time. If they don't stop sleep time feeding practices, if they do not start infant oral care measures, that is cleaning the teeth after every meal and every feed, this will become root stems in another 2 months' time. You will not see the teeth at all. You'll see only the root stems in another 2 months' time. Because you can see the hypoplastic surface, it's very vulnerable, it breaks down easily. Very, very important. So can we say, can prolonged breastfeeding cause ECC? All these things are controversies. There are papers for it, papers against it. Let us not get into that. You see a child with early lesions, and if they are on nighttime or sleep time feeding practices, ask them to feed when the child is awake and give a 20 minutes gap, and also ask them to clean even if it's nighttime. They have to figure out a way to clean the teeth with a wet cotton or gauze after a feed. Okay, and visit the dentist. We can get fluoride application done. We can control this process with the SDF. Multiple things can be done. As a general dentist, you can do many things. You can have a pediatric dentist, or you can refer to a pediatric dentist, but never let these children go out of your office stating that this is all milk teeth, it will fall. Okay, you will lose the family because we will treat the patient. Okay, so the risk factors of early childhood caries. If you look at the risk factors, there are numerous risk factors are there, but I want each and every one of us to just, whenever you have a patient in your clinic or in the department, focus on these 3-4 measures. Okay, there are 100 plus risk factors. We have studied them. We will show you the publication, but these 4 factors are very, very crucial in controlling the disease, in preventing the disease from progressing, and also preventing the disease in total. Okay. Watch out for the sleep time feeding practices. That is, when I say sleep time feeding practices, we'll come to the questions what you have to ask. Identification of enamel defects. You have to wipe off the teeth using a wet cotton or gauze, wipe the teeth, dry the tooth surface, and see whether there is enamel defects. If they are not practicing infant oral care measures, you have to ask them to do it. And also the tight contacts, mainly on the posterior teeth. There are complex contacts, make certain teeth very, very vulnerable. And more research and evidence will come in the next few years. But before that, if you're not take the measures, millions of children are going to get damaged with this problem, right? So let's look a little more into the feeding practices. What is nighttime feeding practices? You know, when you ask question, when I say sleep time feeding practices, you have to ask these 3 questions. You remember these 3 questions, okay? The first question is, at the beginning of sleep, does the child take milk? The second question is, in between sleep, whether the child takes milk. The third question is, early morning, at 4 o'clock or 5 o'clock in the morning, the child takes milk and sleeps for a couple of hours after that. So all these 3 are the different questions, because many times parents have this early morning feeding practices. When you ask them, does the child take milk? They say no, because early morning is not night. So you ask whether the child takes milk in the night. So you tend to, then why did this happen? Okay, but even after taking milk at 4 or 5 in the morning, the child sleeps for a couple of more hours after that. So it accumulates, it sticks to the teeth surface for another couple of hours. Prolonged demineralization, lack of remineralization. So ask these questions, we'll get, I'm yet to see a single child with full-blown ECC, with all upper anterior teeth damaged, and who has said no, that I don't have sleep time feeding practices. It's always 100% yes. So I want you to watch out on this. You ask this question, and this is up to 2 years, 2.5 years. Maybe a child has only one cavity on a first primary molar or a second primary molar. You'll have a different etiology. Okay, but when you have the upper anterior teeth damaged and it's spreading to the back teeth, this is always an yes. You can never get a no. So remember this. So the changes happening during sleep time is, you don't have salivary flow, you don't have muscular movements. So technically, you have only demineralization happening. So we want you to work around, instruct parents around this, how to come back, how to rectify these or come out of these habits. There are methods to do it. So if you see this, it will be always an yes for sleep time feeding practices in a child with ECC, but not all the children feeds this way will not, many children who have this habits will not have ECC. I'll come to the explanation a little later in this presentation. So if one single entity is constantly associated with the disease, is it a risk factor or a causative factor? I'm not an epidemiologist, okay, but it's an important question to answer. Every child comes with the disease. There are 100 plus risk factors, but one risk factor is all the time associated. Is it a risk factor or a causative factor? Okay, is milk the problem or the surface on which it accumulates is the problem? We look at it again. This is one of the most cited paper in early childhood caries research or in pediatric dentistry, or systematic review on risk factors. We reworked on this risk factors. We did this paper, and this was the paper which got the Paul P. Taylor Award. The outcome of this, as an undergraduate student, what you have to remember, one point is the most important risk factor which came out of all the research happened so far in early childhood caries is enamel defects. If the child has enamel defects, the odds of getting early childhood caries is 14.62 times more than a child without enamel defects. So it's very, very important to see this, identify as soon as the tooth comes in. It can be a line, it can be a white patch, it can be a dot, but that's where it's going to begin. That's where it's going to start. So it's easy to identify in a simple infant examination method. A general dentist can identify, a student can identify, it's not a big deal. So this is the most important risk factor. That's the take-home information. This is what is an enamel defect. All the 4 teeth, probably the right lateral has a very minimal damage, but other centrals and the left lateral has more damage. When you have this teeth breaks down, and technically those are the ones, that's why you see many times the laterals are so severely damaged, you hardly see a tooth, even though it comes later than the incisor, because the tooth itself is small, and the entire surface has a patch like this. It breaks down if it's untreated, right? So this is an enamel defect, what we're talking about, okay? So look at clinical features quickly. I'll run through this because you know this. You've read this, all the textbooks talks about this. I don't have to repeat this. It spreads faster to multiple teeth. It affects teeth which are immune, the surfaces which are immune to decay, and early involvement of nerves, because enamel and dentine is very thin in primary teeth, so it gets to the pulp faster. And first the upper front teeth gets damaged because the tongue protects the lower front teeth, but it's not always. I've shown you pictures of early childhood caries with the lower teeth damaged, with all 20 teeth damaged. So most of the time the lower teeth are protected, but at times it is not protected as well. So then it spreads to the posterior teeth. Okay, so this is the nature of the clinical features, right? So we looked at etiological factors. Mainly it's associated very strongly with sleep time feeding practices, and it's also associated with enamel defects. You have to work on enhancing infant oral care measures. Also interproximal contacts, the way the teeth meets each other can play a major role because it allows accumulation there. Okay, if in a spaced dentition, you will not, if a fully spaced primary dentition, you will not see this kind of severe form of early childhood caries most of the time. Okay, so with this quick brief recap, we'll go to the third section of this presentation, quality of life. This is again a very, very important segment I want to talk about, but it starts with one important piece of information. What is that one important piece of information? I put this question: 1 square millimeter of dentine. How many dentinal tubules is there in 1 square millimeter of dentine? It's well established. So many histological studies are done. Look at, we'll take out the first peripheral dentine. That's 10,000 to 25,000 dentinal tubules are there in 1 square millimeter of dentine. Let us not go to the pulpal surface. We have more. We keep an average of 25,000 dental tubules is present, is open, with 25,000 odontoblastic processes protruding through the dental surface in 1 square millimeter. Let us look at these scenarios. How many square millimeter of dentine is exposed in this child? Let us take left maxillary central incisor. You put a mesodistal width of 6 millimeter and take only 1 millimeter across the tooth. That is 6 millimeters. 6 into 25,000 is 150,000 dental tubules are open in one thin line of the teeth. So we all know, we all studied histology, we all studied dentine, we all studied odontoblastic process. Do you think the teeth will be sensitive? Is it a rocket science that we cannot understand, or we are insensitive to this important piece of information? Because even I was insensitive in the earlier days of my postmaster's time, but after spending so much time into this, if you see a child with early childhood caries, this is the first thing strikes me. You know, how on earth the child is managing things. You look at this tooth. Okay, look at the left incisor. How many square millimeters? You calculate probably easily it will be around 24 to 30 square millimeters will be there in only one tooth. Okay, so it's very, very important to see this disease in this aspect. That's why I put this quality of life. You don't have to understand quality of life. You understand this one information, all the quality of life consequences, you will understand default. Because so many teeth are exposed. Look at this. There is no enamel at all. The entire tooth is only the soft dentine. And how many dental tubules are there? Go a little more further. So with this teeth, can you chew hard food substances? So most of these children, they don't chew. They keep the food in the mouth for a long time. How do you brush this teeth? A physical stimulus like brushing is a very hard physical stimulus. It causes excruciating pain and sensitivity to these children. And there are times parents come and tell me, doctor, he refuses to brush. Please do not brush. That's what I tell them. Treat the disease, treat the condition. Everything will change, dramatically will change. So many teeth are sensitive. Parents are not aware that the teeth are sensitive, and because of that, the child is resisting to brush. And the teeth will be extremely sensitive to thermal changes and physical stimulus. Extremes of cold and hot can cause sensitivity because so many thousands of odontoblastic processes are protruding through the teeth surface. Just be sensitive, okay? So this leads to frequent episodes of cough. How does this happen? Because the child doesn't eat well because they don't eat chewable substances. They eat soft and semi-solid, which is more processed food substances, sticks more to the tooth, the disease progresses more. Difficulty to sleep because the teeth is sensitive. A wind blowing at a high speed can cause sensitivity. Okay, and because it's full of bacteria, the child falls sick very often. General health is poor because of poor food intake. And we have done a paper on iron deficiency anemia. It's a significant reason for iron deficiency anemia in children with early childhood caries. It's coming up soon. You'll see the paper. Okay, so the coping strategy is what the children do. They keep the food in the mouth for a long time. They avoid hot food substances and they avoid brushing. They cry and resist, but unfortunately, parents are so worried the teeth have got damaged, and it's happened because of poor brushing, and they try to do it's really doing harm to the child than the benefit without treating early childhood caries. Please do not do that. Okay, so this is the quality of life cycle. You know, the improper feeding practices, loss of enamel dentine, teeth becomes sensitive, poor intake worsens the dental problem, frequent cough and cold, loss of school days, poor quality of life. It goes on. Until you rehabilitate this fully, it goes on. Okay, so be sensitive to their sensitivity. It's a different disease. It's not just dental caries. It's early childhood caries. It functions, it affects in a different way than dental caries. So look at the management briefly. I'll briefly say this. Children under less than 2 or 3 years of age with multiple disease may need a full mouth rehabilitation under general anesthesia. Okay, throughout the world, that's the protocol, and you can work on sedation. You can work on little older children on multiple visits, and little more older children, you can do it on multiple chair side treatment. So general anesthesia is not the only way. General anesthesia, sedation, multiple chair side treatment, all these are treatment protocols for managing early childhood caries. But only if you have a 2 or 1.5 to 2.5 year old with multiple disease, and if you want to rehabilitate fully, if you want to control the disease, yeah, apply SDF, it'll get controlled, it'll get arrested. Teeth will become black, that's fine. Okay, but if you want to bring the teeth back to normal, functional, rehabilitative, and the child should eat well, appear well, functional, everything, then you have to rehabilitate. So procedures are done, which ranges from restorations, root canal treatments, stainless steel crowns, step crowns, zirconia crowns, and all these things. You know, almost entire range of pediatric dentistry procedure happens in almost every single child with a full-blown early childhood caries. So why we need anesthesia? Because any child who's less than 3 years, I want general dentists or students to keep this at the back of their mind. A child who's less than 3 years is categorized as children lacking cooperative ability. It is not that they do not want to cooperate. They lack the ability to cooperate. They do not have the ability at all. So you cannot expect them to cooperate. So that's why they are classified as lacking cooperative ability. And if you want to fully do a quality care, and you know, it cannot be done. You cannot do a strip crown by holding the child and restraining and doing all these at a 1.5 to 2 years of age time, right? You can't put a zirconia crown like that. So it causes a lot of bleeding, right? You need local anesthesia, multiple local anesthesia. and the materials are very sensitive. You know what happens when saliva comes in contact with glass enamel or you are luting cements. So it affects the quality of care. So accept general anesthesia is a part of the management of early childhood caries. Either you have a pediatric dentist who can do it, or please refer to somebody who can do this, because it can be done in 2 hours. 2 hours, the child's life can dramatically change. We do the whole thing in 5 to 6 hours here. I'll run through some post-treatment pictures. So these are like with strip crowns, okay? Fully with strip crowns, a pre and post. If you look at the right side picture, that's done on the chair side. The left side one is done in the theater, because the right side one is a 4.5-year-old child, and this side is a 3-year-old child. Okay, so this is the first 2 pictures which I showed related to the breastfeeding, right? This procedure we did in the theater. It took 25 minutes for us to do the procedure. 25 minutes, the crown's done, the child is taken care, and I still have the right side child with me, because both the children's parents are medical specialists. Okay, both the children parent, okay, they immediately agreed to treat. Otherwise, invariably, many times we lose these children with, they come back later with multiple disease spread to the posterior teeth, etc., etc. This is a phenomenal, probably the biggest change which has happened in my last 2 decades. We got zirconia crowns into pediatric dentistry. You can build a tooth from no tooth. We do a procedure called bite raising. You can put a crown on the D, the first primary molar. It increases the bite. You can build up a heavily broken down tooth with zirconia crowns, right? So it brings the teeth back to normal. Nobody can make out the child has underwent any treatment. Dramatically changes the quality of life. You can brush the teeth normally, eat normally, whatever you want, and brush normally. Everything changes. You have to experience this, what the child went through before the treatment and what happens after the treatment. This can be done in 2 hours. The child gets admitted in the morning at 5 o'clock. 4:30, 5 o'clock we start the procedure, 5 to 7 it's done, 8 o'clock, 8:30 the child goes home. That's it. The disease is treated once for all. Okay, the entire hospitalization is 4 to 5 hours. So there's another child. Can you imagine, I cannot put a strip crown here. We used to use anterior stainless steel crown before in these circumstances, and it serves brilliant. I can show you hundreds and probably 1,000 cases on rehabilitation like this with various in the last 20 years. But you can make a dramatic change. This is an appeal to the general dentist. Please do not let them go stating that it's milk teeth, because we treat these children every day. And many times you lose the entire family, because by the time they know it's treatable, they lose faith in you. Why the general dentist didn't refer to your pediatric dentist, or why they didn't call a pediatric dentist and handle this. So this is a consequence you're facing. The only thing you have not measured, you have not calculated how many families you lost in your practice this way. Okay, it's very, very important information. Never discourage treatment under general anesthesia, but not all children need general anesthesia. It's a integral part of pediatric dentistry. Sedation, general anesthesia, multiple chair side management, all the procedures. It all depends on the number of teeth involved, the age of the child, and the ability to cooperate on the chair. Okay, all these are the parameters. Look at early interventions. Only one patient I'm going to show you, because this is what any general dentist can do. You have to stop the sleep time feeding practices. We are not asking you to stop breastfeeding. Ask the parent to breastfeed when the child is awake, but stop during sleep time or in between sleep time. If at all they have to do it, but still we do not recommend that. But they have to wipe off even in between sleep. How this can happen? It has to happen if you don't want early childhood caries. Otherwise, it will happen if they have enamel defects on the surface, right? So examine the teeth. If you see enamel defects, you can remineralize them. You can bring the teeth enamel back to its original form, but cessation of sleep time feeding practice is mandatory, and they have to start cleaning the baby teeth with, after every meal, every feed, wet cotton, wet gauze wipes to be done. Okay, so they need an early first dental visit, and as soon as the tooth erupts, it can happen. I'll show you this one patient. Okay, this child came to the practice in 2018. What we do in this is the early protocol which we follow in SICRI and in our practice. We ask them to stop the sleep time feeding practice, start infant oral care measures, report back to us. We apply 3 to 4 quick varnish application in 2 months' time. In the 2 months, we apply 2 to 4 visits of fluoride varnish application. So this is the patient, the picture you've been seeing from the beginning of this presentation. You see this after 6 months. Okay, I'll put both the pictures together. This is the first time I'm seeing remineralization with my naked eye. Okay, what you see that you can look at the lateral incisor. You can see the patches of remineralized normal enamel coming back there, right? And you look at the central incisor as well. Okay, so the same. So this is possible only as soon as the tooth comes into the mouth. You have to identify at that stage. With cavitated lesion, the treatment becomes different. Okay, so look at this, the same child 1 year from the time of the first visit. If you closely watch this, all the three images, if you look at August 2019 picture, there's another white line has come down. So there is a patch already, which is an enamel defect, enamel hyperplasia. There's another one coming from the cervical area, which is developed later on during the pregnancy. All these damages happen during pregnancy when the tooth is developed. We don't know the exact reason, cause, but it's all developmental. These are the most vulnerable, which can land up in all four root stems in a very short span of time, where you have to be extremely careful about oral hygiene measures and intervention, what you're doing. Okay, so the hypothesis is, if you have a well-laid road, well-mineralized enamel, if there is an episode of rain, accumulation of milk and other substances, nothing happens because the road is well laid, strongly laid roads. If it's a poorly mineralized enamel, hypoplastic enamel, if something accumulates on the surface, enamel breaks down. This is probably the simplest explanation I can look at why this happens on some children, why it does not happen on other children. So look at, I'll run through quickly some papers from Center for Early Childhood Caries Research. We've done phenomenal piece of work. More and more, the best part of the work are coming in the probably 2021, 22 will be scintillating for us because the results started happening now. So we have protocols, we can control this disease, we can prevent this disease now. But we don't have answers for all, but we know we can prevent the disease, okay? So if you look at this is the first paper, there was a comparison between early childhood caries versus non-early childhood caries. The composition was found to be different. In another series of couple of studies, we found the enamel permeability is more. Primary teeth which had early childhood caries, the enamel was more porous than the enamel of children without early childhood caries. So this is confirmed with a couple of studies. There's one more study. This is a dye permeability study where the dye penetration was more on children with early childhood caries, the enamel on the teeth which is affected by early childhood caries. This is one of the earliest studies which used IGDAS to measure population-based prevalence on ECC. 40% was the population of ECC in this 1,000 plus children, and 20% of them are non-cavitated lesion. Half of the prevalence of ECC is non-cavitated lesion. That means, like the case I showed, if you intervene at the time, they will not come to the diseased population at all. You can arrest the disease by early intervention measures. Very important stage, you have to identify this disease. And we have correlated, there are a couple of other papers. This is an important paper which we particularly developed this questionnaire to analyze sleep time feeding practices called FEAST. It will be out for next year onwards for other people to use. And this is shown on a large case control study. This is one of our Dr. Akila's PhD project. A series of papers are coming in this, which clearly has established that all the children who have sleep time feeding practices with the disease, they always get a yes for sleep time feeding practice. Every single child out of the 800 children. So there's another important area which anybody wants to work on. This is the way teeth meets, the Oakes classification of primary molars, how the first primary molar meet the second primary molar. There are variations in it, and these variations make the primary molars very vulnerable. Some molars are more vulnerable when they have a I type of contact or a S type of contact. It gets into more proximal caries more often than O&X type. So you have some papers coming on this in the coming years because we have done retrospective cohort, we have done prospective cohort studies to understand this more meaningfully, and we don't have any doubts about it now. We have significant meaningful results, statistically relevant results, and which has to eventually, we are very sure that the International Caries Risk Assessment Protocol will take this parameter, very important parameter, which is not in the risk assessment as of today, will change in the years to come when more evidence comes from more other countries as well, more papers come from different studies, automatically this parameter will go into Caries risk assessment. This is why you see many children come with a MO in a first primary molar, DO in a first primary molar and a MO in a second primary molar. This typically happens because of a I and a S type of contact. Okay, so it's a very, very important finding from the center, and a couple of more papers on this classification. Even the pits and fissures, which are trying to study now, the morphological variations like cusp of carpelli can be a significant risk factor for that particular tooth, because they are again, you have variations in it. Very interesting paper. You can write to me, I will email you, anybody who's interested, I can send you all these papers. Very, very interesting papers to read and understand this disease. Another paper on Oakes' contact. Some systematic reviews, and this is the systematic review which I cited before, which brought out enamel defects as the #1 risk factor among the 126 risk factors, which has to be assessed at the earliest possible time. Okay, so it's a very, very important paper. Look at it. And there are a couple of other papers on expectant mothers, systematic reviews. More research is needed. We are developing a project with the gynec department now. Soon it will get funding, and probably we will be on it. You need more research to say something concrete, but we know logically it works. You start at expectant mother, things can be better. You can really prevent the disease much more easily than working from childhood or infancy onwards. So this paper has told, accumulation of all the systematic reviews, all the papers on early childhood caries from India, given a prevalence of 49.6%, but you can't take straight away. That means every alternate child, but not all the studies are population-based studies, so you have to understand the result with a little bit of caution. And this is another collaborative paper from Australia, again working on new mothers or expectant mothers, can give, even though more work is needed, the results can be very promising, that it's an area where we can work on preventing early childhood caries. A quick brief recap on this. Quality of life, be sensitive to their sensitivity. They cannot brush, they cannot eat hard food substances. If they have a full-blown damage, remember 1 square millimeter is 25,000 dental tubules is open. Whenever you see the next early childhood caries patient, count the number of teeth, look at the surfaces, imagine how many tubules are open with odontoblastic processes. So be sensitive to their sensitivity. And management can vary from extreme to pharmacological management, like sedation, to general anesthesia, to chair-side multiple visit management. And we have looked at a lot of papers on enamel permeability and interproximal contacts. And there are more papers coming up on early intervention and for cleft children as well. We will come in probably 2030. I would like to visit from 2010 to 20. I'm revisiting now. 2030 we will visit in a even more exciting way, because we would have definitely known the path undoubtedly to prevent this disease. And the last one, there is something called a National Innovation and Startup Policy. I request the Dental Council of India to look into this, because even engineering colleges have this. It's high time we align some policy pertaining to National Innovation and Startup Policy in dental institutions, because this is something has not happened yet. And we have a startup which provides research consultancy in the name of a meaningful and measurable research progress project. It's called a MRP program. We mentor dental and medical schools to write high-end research protocols to be submitted for funding agencies. So we are into other projects as well, but this is one thing which is relevant to this audience, because I know there are a lot of dental schools, students and faculties are into this, and it can be for dental school as a project. We got the first health incubator now incubated in Ramachandra called BioNest. It's funded through BIRAC. We got around 6.5 crores of grant. So we have these projects through a startup from here, in which Ramachandra University is a part of this project. And the result will lead, if you look at a dental school, you can set up center of excellence, you can develop 10 to 15 researchers, 1 or 2 from each department who can submit protocols. This also can train a team of people who are into PhD, who are younger faculties, who are working to enhance their research skills. This is possible for them. And we also mentor systematic reviews for a team. We also mentor for private practices. Let me not spend too much time on this, but this is an idea. Write to us, communicate with us. We'll come back to this. And this is called a meaningful and measurable research progress. You can look at the website and you can look at the recording of this lecture as well. So coming back, I want to stick to the time. So I'll briefly recap what we spoke today. I consciously avoided certain things which are very much normally available in the textbooks. Okay, so we looked at the extreme. It's not the disease which only affects the upper anterior teeth. It can affect all the 20 teeth. So you have seen in the extreme, and the terminology states even one single non-cavitated lesion on single tooth surface is early childhood caries. When you see the next child, you look caries free, but you see a white patch on the maxillary left central incisor, you diagnose that as early childhood caries, because then you can remineralize that. Okay, but if you diagnose that as a caries-free dentition, that means you have not used the definition of early childhood caries. The younger stage, it can start as soon as the tooth comes into the mouth. So you have a very, very narrow window to prevent this disease. You miss this, the disease sets in. The disease sets in, you have to rehabilitate them. Etiological and risk factors, very important association with sleep time feeding practices, and work on enhancing infant oral care measures, and also early intervention protocols. Remember, enamel defects is the #1 risk factor based on available literature. So you look at white patches, I've shown you how you can remineralize an affected enamel. I have a series of cases. You give me 6 to 7 hours, we do a workshop on early childhood caries. Okay, I can see you what failed, what worked, what didn't, and what are the factors involved in it. Why some teeth surfaces are affected, why some parts are not affected. You can calculate when they stop sleep time feeding by the surfaces affected inside the mouth. You look at the teeth, the number of teeth affected, the surfaces involved. The teeth comes after the cessation of sleep time feeding practices will not have the same damage like the teeth which came before. So you can make phenomenal amount of inferences from the pattern of disease. And we looked at clinical features. We know that it affects multiple teeth, starts from the upper anterior, goes to the posteriors, and tongue protects the lower front teeth most of the times. And remember that child with severe disease have very, very significant limitations in quality of life. They can't eat well, they can't brush well. Do not do conservative management, dump some GIC and manage that. That will not prevent their sensitivity. Exposed dentine will cause sensitivity. So you have to put a crowns. Either you learn it or you call a pediatric dentist and get it done. Okay, either way, let us treat this disease. Let us not say that it is milk teeth, it will fall. And the risk for getting cavities in permanent teeth, if the child has early childhood caries, is 90%. You have early childhood caries, there is a 90% chance that you will get cavity in the permanent teeth, because by the time the teeth falls, it's 12 to 13 years. By the time all the teeth have come into the mouth with untreated primary teeth with cavities. So it's a very, very important aspect. Management ranges from chair side to pharmacological. We explained, we recap, and we done some. Anybody is interested in research focused on early childhood caries, looking at projects, we can write projects. You can get yourself associated with us as a research associate. If you have a master's degree, if you have a PhD, it's even more easier. But if you have a master's degree, still we can make projects and you can become a research associate. There are so many funding agencies available, so much money available for research funding in this country. And be innovative, read the national innovative and startup policy. Let us work on bringing more research, meaningful research, which will benefit the society and translate. And let us also play a small role in the government's aim to a $5 trillion economy in the coming years. And to conclude, I read the conclusion. Managing children with early childhood caries is an uphill task. Understanding the disease process is important to provide cure for this completely. Knowledge about the treatment that lasts longer, challenges in providing dental care, chairside or general anesthesia, availability of the various restorative options like anterior and posterior stainless steel crowns, strip crowns, zirconia crowns, treatment options that will fail often, and the ability to convey this effectively to parents is important. The ability to decide to treat in the OT or on the dental chair is vital. The changes the treatment can provide to these small children has to be experienced by a clinician. The change in quality of life of these children after the treatment is miraculous. It has to be experienced and cherished. You can experience the sacredness of being a healthcare provider, ability to relieve somebody else's pain, ability to make life comfortable, ability to make the child eat and chew better, ability to make them smile confidently, ability to bring back function, shape, size, color, and many more things for the little ones who never knew what a normal set of teeth was. Once again, we can be proud and privileged to be a pediatric dentist in this lifespan. I stop for questions and answers. I'm probably whatever questions you can throw across. Back to Dr. Baliga.
Thank you, Dr. Muthu, for this amazing presentation. I think you have sown the seeds of innovation in early childhood caries among this new crop of students who have been a part of this webinar. I think, as you know, it is rightly said, catch them early, catch them young. I think these guys have to really focus. And I think you have the way, I think the conventional way of what is there in the textbook is not what I think those students would be expecting. I think you have put in a lot of light, thrown a light on the innovations and the newer aspects of early childhood caries, because what we have seen in routine R books and what we have been reading has been always standard. I think looking at that perspective, the way you have put out your presentation, I think there should be some kind of an igniting minds, which definitely would be a part of research. I think that is the core area which I think this country will be looking up to in this decade. I think there's a lot of clarity which you have given in, I think, the oral hygiene practices, the feeding practices, and the work which has been done on it. It is really exemplary, and I think I congratulate you on this. I think a couple of questions. I think I will take in the top 10 questions which I think the students they have raised on. Just a second. Yeah, there's a question on how much does a milk play a role in causing early childhood caries. This has been raised by Revati B.
Yeah, as I told earlier in this presentation, if you replace milk with something else, which is a carbohydrate, and if it is accumulating on a rough surface or a more porous surface, it will break down. It doesn't matter what milk it is. So milk plays a role because milk is the most common substance being consumed in the night time. You go across the globe, the substance is the same, right? It's in bottled milk or breast milk, it can vary. But we looked at the composition of milk. The breast milk is more viscous than the bottled milk. That's one of our recent studies. So again, we have to be very clear in this aspect. We are not blaming the breast milk. If the tooth is maintained, if you clean it up, okay, and if you identify if the enamel defects are there, then even breast milk can be more damage causing on a defective enamel. So it's identifying the defecting enamel and addressing that should be our concern, because breastfeeding has a lot of other benefits as well. And there's already a controversy on this aspect. So let us not blame the breast milk or the milk per se. Let us work on the tooth surface and oral hygiene measures, and we can overcome this and reorganize the sleep time feeding practices to little more awake time feeding. I know it's easy to feed in the night time, but see, I don't think a year back nobody would have ever agreed to wear a mask. We felt it's necessary. Now nobody feels ashamed of wearing a mask and going in the road. In fact, people come with the shields as well, right? We don't feel bad at all. But a year back, this was not possible. Nobody would have done it if you asked them to do it. Because now there was a need came, a crisis came, we started accepting it. So let us understand this as a crisis, and let us work that way. Then we'll work around, because I always ask the pediatricians, will the breast milk cause goodness only if the child is fed in the night time? Will it not give the benefit if the child is fed awake? Can't we work towards enhancing efforts or find out ways and methods where we can feed when the child is awake? So we'll continue feeding till 2 years. But let us let us start talking about it. We'll figure out the objectives, we'll figure out the limitations, and we'll work on that. So it's a very important question, what role does the milk play? Even if without milk, it can still have the problem. Even if you give Coke or anything with sugar, or without sugar also, it can still cause the damage, because it's prolonged accumulation, which causes prolonged demineralization without any intermittent phase of remineralization. That's a major issue. Okay, it can't even the food substances will accumulate and stay there. Okay, if it's a sticky food substance, and most of the cereals are sticky, so it will stick there. So if the surface is smooth, it sticks, the surface doesn't break down. But if the surface is porous, microscopically, it gives way easily.
So the second question is by Mr. Sumit Garg, anything for daily or topical application by parents to prevent caries initiation or delay caries initiation?
The best is using fluoridated dentifrice. The current recommendation, even for an infant, you use a pea size or a rice size, a small quantity of fluoridated dentifrice. That's the easiest source available for everybody. Okay, that's the best way you can apply. But if you see these kind of early changes, what I showed in the presentation, try to visit a dentist, visit a pediatric dentist. If you don't have pediatric dentist in your place, visit a dentist, but let them dry and see, wipe off and see the extent of this thing. And those circumstances, the fluoride application, the professional fluoride application can help, mainly the fluoride varnishes. More than the gel, the fluoride varnishes can really help in a big way in remineralizing.
One more question from Nishta Arora. Apart from diet monitoring and good oral hygiene, what supplements can be suggested to children of around 1.5 years of age?
Diet monitoring and supplementation.
Good oral hygiene. What supplements can be given, can be suggested to children of probably pre-cooperative age group?
Okay, actually, see, basically one of the most important simple measure for a pre-cooperative child in a large scale measure, if you look at 1 and 2 years, don't introduce sugar. This is the best, probably the most simple public health advice I have ever heard in my life, last 20-30 years of dentistry. You know, don't introduce sugar up to the age of 2 years. Brilliant piece of public health advice. Okay, the infant doesn't ask sugar. We only add sugar. So easier thing is to not add sugar at all in anything and everything up to the age of 2 years. Brilliant, very, very effective public health measure. And another thing is, make sure the child sleeps with the mouth clean. More than morning brushing, the night brushing is the most important aspect. So when the child goes to sleep, mouth should be clean. The next thing is, wipe off or clean after every meal or every feed. It is not morning and night brushing. I keep telling this when we see this 1.5-year-old, 1-year-old. It is not morning and night brushing. It is after every meal, every feed. When you prepare a bowl of food, prepare a bowl of water, put a piece of cotton in it, put a piece of clean cloth in it. You know, after the feed, squeeze the cotton, wipe off the teeth. Very simple, profound impact it will have in terms of preventing caries. But it's a habit a mother has to develop, and it's not one simple instruction which you give it to the parent, because they take the instruction, they go back and they don't do it. You have to insist, repeat and insist on this. Then they may go back, and many of them can do it. And they also should know the consequences if they don't do it. This is what will happen. I always show this picture of ECC in my ECC consultation. If you don't do this, this is where you will be in the future. And this is where we will treat it in the hospital. And this is what will happen. In fact, the cost of the things and other things. So the simple supplements and intervention are infant oral care measures and nighttime cleaning, and don't give any sugar. Don't introduce sugar up to the 2 years of age. You know, that's one of the best advice you can give to them.
There's another question by Dr. Vatsala. Do we use the terminology rampant caries, nursing bottle caries, or do we use the term early ECC as diagnosis?
ECC only is the term used. Rampant caries is not used since 1998. So rampant caries probably you can use on adults where they have caries in the upper and lower teeth. You know, you see some very rarely you see adolescent teenagers, and also in the extremes who have underwent radiotherapy and things like that, where multiple teeth gets damaged. You can classify them as rampant caries, but in childhood less than 6 years, it's only early childhood caries. No other terminology is used. It's all for, probably you write an essay, in your historical perspectives, you can give all those terminologies.
There's a question by Anand George. Can masticatory training be added to the follow-up treatment of an ECC survivor, as they have never been exposed to normal mastication pattern?
Yes, bite force assessment. If you look at the literature, there is very handful of papers have done on bite force assessment. Okay, because it's very difficult. You know, you have certain devices. If you assess the bite force, I can bet you on this. I don't think a child with all the molars damaged, with dentine exposed, they will have significant defect in biting force comparing to a child with an intact primary molars. 100%. It's a logical thinking with the dentine histology, knowing we know the dentine histology, all those things. So bite force measurement can play a major role. One of our systematic reviews coming up now on we have around so many studies, but in early childhood there are only a handful of studies they've done. But again, before treatment, post treatment, probably there's only one study as of now. So more research needs to be done to establish this concretely. Okay, but that's an interesting aspect. It can be a, you know, you can prove this to the parent. You have the bite force device in your clinic. You can measure it before the treatment and rehabilitate them. Call them 1 month later, ask the child to bite. You will see objectively the numbers will definitely change, because the child will be able to eat comfortably, bite comfortably without any sensitivity. I've seen this dramatic. You know, parents have cried, doctor, we never knew that this child was not eating because of this, because of the teeth. We rehabilitated this, and you know, you can read the reviews on Google's. You know, tremendous changes can happen in this aspect. It's extremely satisfying and gratifying being a healthcare provider when you can do this, changes in the bite force happening after the treatment.
There's a question by Dr. Rahul Bhautek. Primordial preventive strategy, that is, can education and counseling of mother at the time of first vaccination help in reducing early childhood caries?
Yes, definitely, 100%. Because that's why we are, as I told in the presentation, expectant mothers. See what happens, what I came to know, we recently had an idea. Expectant mothers, you tell them they are in a more receiving mode because they don't want any problem for the child, right? We all have seen as senior people, during pregnancy, the mother is very receptive for any advice, any information. So if we can have a proper pediatric dentistry gynecology partnership in an institutional basis, wherever there is a possibility, where there is a pediatric dental resident visiting their department on a regular basis, communicating with the mother, show the intact teeth and the damaged teeth as well. How this process happens, as a simple explanation, I'm telling you, you don't have to tell them. They will come. At least half of the mothers will come for the first dental visit without any effort, because you already told them that when the earliest change happens, they will definitely remember you, because you already told them this is how it will start. It's going to break down if I don't go. So they will not wait. It's milk teeth. You know, there are neighbors will be telling them, you know, it's milk teeth, it will fall, but still they will remember you because you consulted them. That's the best primordial prevention you can do for early childhood caries prevention. Another thing is, many times the pregnant mothers gets their mouth ready, you know, before pregnancy. And, you know, they don't want any dental problems and other things. Some of the well-educated ones, and also on IVF and things like that, right? So the mouth is clean. Then the transmission also becomes less. The Streptococcus mutans transmission also becomes less, or it gets delayed. And the chances, the risk for the newborn is going to be less if the mother's mouth is clean. There are good amount of papers are there, but more research is needed there.
There's a question by Dr. Chitra Girija Vallaban. What is your opinion about tooth mousse effective in these cases?
Tooth mousse is a very good remineralizing agent, but we haven't studied on the white spot, which I showed at 12-14 months, because you need something more sticky. That's why we still use fluid varnish. But I've seen many times, the sad part is, many times a full-blown early childhood caries, full cavitated lesions are there. Parents come with a tooth mousse tube that the dentist gave this to use to handle this. The child is 2.5 years. This is very, very unfortunate. Tooth mousse cannot do anything. Tooth mousse can remineralize white spot lesions, but I have used them on hypoplastic permanent incisors, okay? And we make a soft splint wherever there is hypoplastic spot, and we mark in the stone cast. We take an impression, we pour a stone cast. In the cast, we mark which all teeth has hypoplastic areas. We mark it. We add little more stone onto this hypoplastic area. Stone, we make it a small mountain of stone there. We send the model to the lab. They make a soft splint. When they make a soft splint, this mountain of wherever the hypoplastic area is there, it becomes a well. Okay. Now you take the soft splint, put the tooth mousse into the soft splint, wear it in the night and sleep off. Localized delivery, where you want it, you get it. So this has worked very well, phenomenally well. You can definitely remineralize. So it's not a treatment for a 2-year-old or a 3-year-old for early childhood remineralization or a cavitated lesion, which is most unfortunate. Please do not do that.
There's one more question by Dr. Vedangi Mohite. Sir, would you comment on the care pathways for uncontrolled and controlled early childhood caries with its effectiveness on concurrent remineralization strategies?
No, I'm not familiar with that, or we have never tried that kind of an approach. Whatever the early intervention approach we have experimented with a cohort of cleft children from birth to 2.5 years. We have a good experience. We could prevent disease significantly, but we follow a principle called sustained anticipatory guidance. Anticipatory guidance is an established textbook thing, but we use a philosophy called SAG. It's called sustained anticipatory guidance, and it's coming in the textbook now, and more work is happening. I don't have prior experience on the care pathway, what is being asked.
The last question of the day is by Dr. Supriya Bhatt. How is that even after following all the preventive measures, there could be occurrence of caries?
Yeah, it's a brilliant question. Probably the last question. See, there is a lot of literature says that a child who has early childhood caries, rehabilitated in the hospital, mainly in the Western setup, or even in Indian scenario as well, we rehabilitate them fully. And this is what we also used to do 10 years back, probably 8-10 years back. We rehabilitate them. Okay, mouth is clean now. The child goes home, and we tell them you have to see regularly. We have to come after 6 months. They don't come after 6 months because the disease is treated. So we never insisted on follow-up. Remember that children who had early childhood caries have a very high risk for developing new cavities in the future. This risk is very much controlled in the first 12 to 14 months of age. The bacterial levels are very minimal because you've treated them all. There are no active surfaces. Okay. So as you go along, once you cross the 12 to 14 month window, the more bacteria start coming in, more colonization happens if they don't practice good oral hygiene practices. What do I mean by that? They cannot compromise nighttime brushing. You have to insist on them. Oral hygiene, mainly brushing in the night, is very, very important. Okay. The second thing, one of the reasons why this happens is, many times as an early pediatric dentist in my earlier days, we never used to treat these white spots. Okay, these white layers are left out, white lines are left out. So you treated the cavities. We've trained to treat cavities, right? So we treated the cavities, we put crowns, we put restoration, we put strip crowns, but we left out all these white lines in here and there. And they come back with the canine class 5. They come back with new cavities on the interproximal contacts between D and E. On the proximal, you put an occlusal filling, class 1 filling, but it had an S type of contact. Now we know that it's a complex contact. So you have to work, the child should be on extraordinary preventive measures to prevent cavitation in a S contact or eye contact. So it is very important. The best remedy, the best way to do this is, you call them, the protocol what we have in the practice is, after the rehabilitation, we see them within 2 days, and we tell them, we reiterate many times that the first year we need to see you minimum 3 times. Minimum 3 times. So 3 months, 3 months, and 6 months. The second, if all goes well, the second year I will see you once in 6 months. If all goes well, probably, if I'm very confident your night brushing is in place, you have not developed any new cavities, then the risk is under control. But if you don't insist on this, and anybody who stuck to this protocol, I can show you children who never developed disease for 8 years, 10 years after one rehabilitation. But at the same time, there is a small segment who don't keep up the follow-up. In spite of the reminders, they don't come back for the follow-up, and they stopped night brushing. What the most important thing I want them to see is, I ask them, are you brushing in the night? Or I'll ask the parents, do you supervise? Okay, because it's important that the child is brushing, and it's important that parents or brushing, if the child is 5-6 years old, until 6-7 years, the parent has to brush. So there is always this conflict going on. The child will brush, the child will take care of brushing. Mother will say, no, he himself only brushing. It's not going to happen that way. Okay, so you have to ask the parent or caretaker to brush in the night. If the child wants, child can have a turn. So all these factors play a role in the recurrence of this disease. Okay, we have very, very limited research on this. But a lot of published papers says, because nobody comes for follow-up. If they don't come for follow-up, they always carry on this higher risk. They don't brush in the night. Everything happens again, more surfaces gets damaged. If you handle these frequent visits and frequent reinforcement of oral hygiene measures, you can largely prevent this. And we have numerous cases followed up that way.
Yeah, thank you so much. I think that ends my question answer session. Over to you, Dr. Muthu.
Yeah. Thank you very much for, I should, my humble thanks once again to the President of DCI, the Vice President, the Secretary, the office bearers who have thought about this webinar series, who have given many excellent clinicians and researchers to one of the biggest audiences, Dr. Virender Goyal, Dr. Mukesh sir, Dr. Kishore, Mr. Kishore, Mr. Mukesh, everybody. And our sincere thanks for making this possible. Thank you very much for giving me an opportunity. I'm grateful for, to share this whatever we have learned over these 10 years to a large group of students and faculties. My sincere thanks again.
Thank you so much, Dr. Muthu. Well, for those people who logged in late, I think this is the highest attendance in the last webinar which was conducted by the Dental Council of India. The college names are as follows: St. Joseph Dental College, Elu; Sardar Patel Postgraduate Institute of Dental and Medical Sciences, Lucknow; Guru Nanak Institute of Dental Sciences and Research, Kolkata; Indraprastha Dental College and Hospital, Ghaziabad; Saraswati Dental College, Lucknow. Next webinar is scheduled on 3rd of January, Sunday at 4 o'clock. The topic is tobacco cessation and dentistry. The presenter is Dr. Vikrant Mohanty. He is Associate Professor and Head at Public Health Dentistry Department, Maulana Azad Institute of Dental Sciences, New Delhi. And the moderator for the same is Dr. S.S. Hiremat, Professor and Head, Oxford Dental College Hospital and Research Center, Bangalore. Well, to conclude, I think firstly I would like to really thank Dr. M.S. Muthu for taking out time to address the entire young crowd as well as all the teachers on such a vital topic with such clarity and detail. First, I would like to also thank Dr. Bharat Shetty, the President of Dental Council of India, the Secretary Dental Council of India, and Dr. Rahul Egde, the Executive Committee member of the Dental Council of India, inviting us as moderator and Dr. Muthu as the speaker for this such a vital topic and such a beautiful webinar conducted by them. I would also like to thank Dr. Virender Goyal, Mukesh ji, and the entire technical team of Dental Council of India in having conducted such a wonderful and successful webinar. Thank you so much. We'll meet up on the next Sunday. Thank you.
Thank you.